Should you have a vaginal examination in pregnancy, labour or birth? This is worth a watch and a save. In this video, I'm going to go through all the different reasons you may be advised or recommended to have a vaginal examination at any point from the moment you conceive all the way to the postnatal period where sometimes some examinations are recommended. You may see that some creators advise to have no examinations whatsoever. In this one, I'm going through reasons. In the next video, I'll go through risks and benefits. And in the final one, I'll go through what your midwife is actually looking for in that examination. Now, it's important to note anything that is being inserted internally, whether that's fingers, whether that's an ultrasound probe, for example, whether that's a speculum examination, requires your informed consent. You have the option to say no. All the reasons why you're being recommended should be explained to you with the risks and benefits before you choose to have one or not. So beginning in early pregnancy, sometimes a transvaginal ultrasound scan is the only way to be able to detect that early pregnancy. So if you've got any bleeding or abdominal pain that might be indicative of things like an ectopic pregnancy, or where that maybe might be growing, for example, a transvaginal ultrasound scan is sometimes used in those early stages. This involves an ultrasound on a stick to be inserted with your consent into the vagina. One common reason at the end of pregnancy, all women in the UK are offered something called a membrane sweep who are planning on a vaginal birth. A membrane sweep sometimes helps to stimulate the start of labour spontaneously without the need for going on to formal medical induction of labour methods. Membrane sweeping is still an intervention in itself though, because it is trying to bring on labour potentially before the body is ready. As your pregnancy continues, if you have bleeding, any signs that your waters might have gone, or any concerns with discharge or loss, for example, signs of a miscarriage with abdominal pain, or as your pregnancy progresses, threaten preterm labour where labour comes and goes, you may be recommended to have a speculum examination and or a digital examination to be able to appropriately assess what's happening with the cervix and then potentially offer interventions that may help with that pregnancy continuing, or to be able to manage it effectively. For example, if your waters had gone early on, antibiotics to reduce the chance of infection. I've done videos on membrane sweeping before. They are in the Induction of Labour series if you want to find out more. If you choose to have an induction of labour, the very first part of that induction of labour process will be to examine to see where your cervix is at. Because if your cervix is closed, cervical ripening methods will be needed to help with the induction of labour process. This might be pessaries, this might be gels, tablets, this might be the balloon catheter induction that I've done videos on before. But the first part of that induction process will be to examine your cervix to see what the most appropriate and best effective method of starting the induction of labour process will be. If your cervix is thin enough, open enough, it may be that your waters can be broken at this stage. If at any point within your labour or birth there are concerns with your baby's heart rate, maybe it has dropped, maybe it's really sleepy, there's been no accelerations in your baby's heart rate, an examination will do two things at that stage. So firstly, fetal scalp stimulation. This is where we tickle the baby's head with our finger. We're not doing a stretch and sweep, we are tickling the baby's head itself. If there is a heart rate increase, that's called an acceleration, that tells us your baby is getting oxygen to the brain. That's a good response to have, and it's called fetal scalp stimulation. And it's an intervention, but it's an intervention with purpose because that helps guide your midwives and doctors to know, is your baby still getting enough oxygen? Can this labour continue? Is everything okay? Tickling their head normally gets them excited and they should accelerate with that fetal scalp stimulation. The other thing that examination is doing though is seeing whether there are waters in front of your baby's head and having a feel to make sure that it is just a head and not a cord in there. Also to confirm that again, is it a head? Is baby in the right position? Is there a hand or a foot coming through the cervix? Because that all has impact on the safest method of birth. It's important to note though, with a cord prolapse, the midwife will need to keep their fingers there until the baby is delivered, and that's because we're placing pressure on the baby's head to release the pressure on the cord, and that helps provide more oxygen to your baby until they are born. It is important to recognise that even in an emergency situation where a vaginal examination might be life-saving, you can still say no. You can have that final say, you can remove consent at any stage, but you do take on board weighing up what the risks of saying no are in that situation. So for example, in a cord prolapse, if that finger was removed, for example, it may deprive baby of oxygen. That may have impacts in terms of outcomes for baby. If a woman is conscious and has the mental capacity to do so, they can take consent away to examine at any point for any indication that exists. One of the most commonly used vaginal examinations in labour and birth are to assess progress, to try and detect obstructed labour. That's where labour stops and doesn't continue, and it can have implications for both mums and babies. Assessing progress is usually recommended by most trusts around 4 to 6 hourly in established labour. So the moment your contractions are really regular, really strong, assessing progress is normally recommended between 4 and 6 hourly of vaginal examinations. There is little to no evidence to support its use. However, for some mums, it brings them reassurance, it brings them comfort in knowing what their cervix is doing. For some people having an induction of labour, it's knowing that the induction is working effectively, the body is responding to the medications, and that's purely because prolonged labour and prolonged induction of labour can have risks to mums and babies. So that examination is just confirming, is this working, is this still the right mode of birth, the safest method of birth for both mum and baby. But it is important to note that this is not a crystal ball when you do an examination to assess progress. It doesn't tell you we're going to be in 1 minute, 5 minutes, 10 minutes, 10 hours. It's literally a snapshot, a photograph in time of what is happening to your cervix when the examination is purely to assess progress. If there's been a prolonged pushing stage, the examination will be assessing what position in your pelvis your baby is in as well. And that might indicate that maybe a forceps or a ventouse might be recommended by a doctor, for example, particularly if baby is back to back, for example, slightly skew-if in the pelvis. In a forceps or ventouse, sometimes a doctor will manually rotate baby's head as well into a better position to help with the delivery of the baby. Now, more rarely, shoulder dystocia manoeuvres will involve someone inserting their hand to be able to release the shoulder. Now, 1 in 200 births have a shoulder dystocia. However, 85% of those are released just by moving the mum into a different position. So around about 1 in 1,000 births, a midwife might need to insert their hand, or a doctor, to be able to help release the shoulder, to be able to help deliver the baby safely and dislodge the shoulder dystocia. But these are rare and uncommon. After birth, the vagina is recommended to be examined to see if there are any stitches needing to happen to help reduce the chance of postpartum hemorrhage and infection if stitches are required. And at the bottom, examination is also usually recommended, again to check that there are no tears between the vagina and the anus that might need more specialist treatment. Pain relief can also be inserted, which provides really effective pain relief after any stitches or for any after pains too. In a caesarean birth, a swab on a stick is used after birth internally to be able to help remove any clots, which helps to minimise infection, but also helps to reduce the chance of postpartum hemorrhage because it gets rid of any clots that might be at the top of the cervix there. There might also be pre-swabbing now as well. Many trusts are now doing pre-swabs, so that's after the catheter is inserted into the bladder. A pre-swab is done with some cleaning agents, and that's to help reduce the chance of infection. 1 in 10 caesarean births has an infection. There are some people who are more at risk of it than others, and that pre-swab is showing in early trials to reduce that infection risk for mums and babies. So that's a swab on a stick to clean out internally before the caesarean birth starts. And finally, if there's a postpartum hemorrhage, so that's excessive blood loss at any stage, or if the placenta has not been delivered, that is another reason why an examination postnatally might be recommended. This internal examination is normally done with swabs and gloved fingers. However, if a manual removal is needed, this is done in theatre with a spinal or epidural anaesthetic, and where the obstetrician puts their hand inside to remove the placenta completely. In the rarest situations, and I mean rare, I'm trained in it as a midwife, I've only ever heard of one in my entire career from another midwife in a different part of the country where she's had to use this, but bimanual compression is another thing. And that is where the person has to insert their hand and actually clamp down the uterus in really life-threatening emergency postpartum hemorrhages where you know that there's going to be a delay. For example, a long journey from a home birth situation and there's a lot of blood. Or if theatres are completely full in a unit, it is done incredibly rarely because it's quite uncomfortable to have done. That manoeuvre helps to clamp down the uterus and stop the bleeding, but it is the rarest. Like I said, in 16 years, I've heard of it once in a completely different part of the country at a home birth. So whilst we're trained, we don't use it very often.